Okay, hi everyone. So we are going to talk about capnography today. This lecture is going to be a little bit shorter, or a lot bit shorter actually, than the clinical monitoring, because this is about 33 slides versus the 91 slides. So this one shouldn't be as long, and we'll discuss it on Monday. So we'll just get right into it. All right. So the importance of capnography, it's a standard monitor that's required by the AANA and ASA, and it's required for every patient under anesthesia. Excuse me. So it doesn't matter whether it's general or it's considered a MAC. If you're just using a nasal cannula, that can go back and forth how people consider that a general or a MAC depending on what type of anesthetic you're using. You always need to monitor capnography no matter what. So capnography gives us a lot of information. It gives us our ventilation status and allows us to see metabolism as well and our cardiovascular status. And so a lot of times we can think of it as an electronic stethoscope. So it just basically is showing the cyclic appearance and disappearance of CO2 as we're monitoring the patient. So the effects of hypercarbia, we see respiratory acidosis. It also increases cerebral blood flow, which thus increases ICP in certain patients. And we see an increase in pulmonary vascular resistance, and we also see potassium shifts from intracellular to intravascular. Now, the effects of hypocarbia are going to be opposite, essentially, of hypercarbia. So we will see respiratory alkalosis. It decreases cerebral blood flow. And we see a decrease in pulmonary vascular resistance, and potassium is shifting back into the cell. And it also blunts the normal urge to breathe. So you'll see sometimes when our PaCO2 gets too low in a patient that they have that normal urge to breathe has been blunted. Okay, so some general concepts. All right, it provides information primarily on ventilation, but also we also can see information regarding pulmonary blood flow, aerobic metabolism, and primarily placement of the endotracheal tube or LMA, which is what we love to see. We like to see in title when we get it in the right location or the right place. Then also gives us information about the integrity of our breathing circuit, and it estimates the adequacy of cardiac output. And so it's also kind of in the last few years become a standard to be using within for CPR to assess the adequacy or inadequacy of CPR chest compressions to ensure that that there is adequate cardiac output when from the chest compressions when a patient is in cardiac arrest. Okay, so some more general concepts. So dead space. Dead space is the volume of each breath that's inhaled that does not participate in gas exchange. And there are specific regions or other definitions of dead space as well. So anatomic, it's the large conducting zones of the airway, so the nose, the trachea, and the bronchi. And physiologic, dead space is the airway, so the nose, trachea, and bronchi, plus alveolar dead space. Alveolar dead space is the portion of the physiologic dead space that does not take part in gas exchange, but it's within the alveolar space. So again, dead space represents the volume of ventilated air that doesn't participate in gas exchange, and there's the two types, the anatomical and the physiologic dead space. And basically, the anatomic dead space is represented by the volume air that fills the conducting zones that are the nose, the trachea, and the bronchi. And the physiologic basically includes the anatomic or the airway, and it's plus the alveolar dead space, which is the portion of the physiologic dead space that does not take part in gas exchange, but is within the alveolar space. So the conditions that increase alveolar dead space are VQ, and basically when we are showing that there's an increase in alveolar dead space, there's a problem with VQ mismatching. And so usually with that, it's there are regions of the lung that are being ventilated but underperfused. So if we have any conditions that's going to result in a VQ mismatch, we're going to have an increase in alveolar dead space. So hypovolemia, pulmonary hypotension, a pulmonary embolus, ventilation of non-vascular airspace, obstruction of precapillary pulmonary vessels, and obstruction of the pulmonary circulation by any external forces. So, for instance, if you have a surgeon that could be working in the chest cavity or in the thoracic cavity, and they clamp a pulmonary artery, or if they are pushing upon parts of the lungs that are compressing parts of the capillary bed, that is causing an obstruction, and that would be an obstruction by an external force or even like a tumor. So a tumor could cause obstruction as well. And then overdistension of the alveoli, which we see that quite frequently in emphysema. So the Bohr's equation basically is calculating the physiologic dead space, and it's a ratio that is looking at dead space to tidal volume, and it's just essentially just calculating the physiologic dead space in the lungs. That is it. All right, so terminology here. So capnometry, that is the measurement and quantification of inhaled or exhaled CO2 concentrations, and is measured by a capnometer. And capnography is the method of CO2 measurement and a graphic display of time. And it also basically is the detection of carbon dioxide breath by breath, and the best method to confirm endotracheal intubation. So it's a gold, you could say capnography would be the best way, the absolute best way to indicate that we have intubated a patient and the tube is in the correct place. Now, however, and we'll talk about the color changing indicators in a couple of slides, those and the sensitivity and the problems with those. So it could turn color, but you could still actually see that even with a esophageal intubation, it would turn color. And so it's not always the best indicator and for the color change indicators, but if you're not using a color change indicator and you have adequate CO2 on your monitor and you see a good waveform, then you know that you're in the right place. Okay, so time capnography. So essentially, it is a graphic representation of the partial pressure over time. So it's plotting pressure over time, and it's the most common representation that we'll see. And the CO2 concentrations are digitally reported as inspired and as in tidal. And most of the time-based capnograph devices can be configured to display the CO2 traces at two different speeds, and those speeds are high speed and low speed. And so with high speed, we can get information about each breath, so on a breath by breath basis. With slow speed, we see the trend. So we can look over an entire respiratory cycle and we can see the trend, like whether we're trending upwards with our end-tidal measurements or downwards. So with high speed, we get that breath by breath information for each breath. And for slow speed, we're looking at the trend. We're looking at the trend there. Okay, so side stream and mainstream, we've talked about both of these a little bit. And with side stream, it aspirates the gas sample away from the patient and analyzes it away from the airway at a rate of about 50 to 200 milliliters per minute, and it's the most commonly used method of gas sampling. And there is a transport time delay, and there's a longer rise time as well. And so with mainstream, it analyzes the gas sample directly within the breathing circuit, and there is no time delay with this one, and the rise time is faster. So when I'm talking about the rise time, basically it's the time required for the analyzer to respond to a sudden change in the CO2 concentration. So the rise time is going to be longer or more delayed in the side stream because it's still got to travel through the tubing to get there, right? And then with the mainstream, the gas doesn't have to travel anywhere, so we can see a change in a change in the CO2 concentration a lot faster in the mainstream versus the side stream. All right. So our end tidal CO2 is measured at the end point of phase 3, and you see that arrow right here. And so the method used to determine this number is not universal, and it actually varies according to the manufacturer of the particular capnograph in use. So it could either be the PCO2 or PaCO2 value just before inspiration, or it also could be just the largest PaCO2 value during a single exhalation cycle, or it could be the PaCO2 value at a specific time or a specified time in the capnograph that's averaged across several breaths. So, I mean, there's it's just different ways that it can be measured, and it just varies by the different manufacturer. Okay, so it also is seen as P end tidal CO2, and you'll see it in both books written that way, and it's essentially referring to the partial pressure of end tidal CO2, but it's not any different from when you see just ET CO2. So just know that you may see it written differently, but it's still referring to the same value. Okay, so now we're going to look at the causes of increased end tidal CO2, and so we see that there's the increase of CO2 production and delivery to the lungs, so that will cause an increase, or a decrease of alveolar ventilation, that will cause an increase, and any equipment malfunction. So starting with the increase in CO2 production and delivery, so an increased metabolic rate, fever, sepsis, seizures, MH, thyrotoxicosis, or hyperthyroidism, increased cardiac output, so like during CPR, and bicarbonate administration. Those are all going to increase the CO2 production and delivery to the lungs. Decreased alveolar ventilation, so hypoventilation, anything that's going to depress the respiratory center, so opioids, for example, or some of our anesthetics. Partial muscular paralysis, muscular disease, neuromuscular disease, and a high spinal anesthesia that can decrease our alveolar ventilation as well, and COPD. And equipment malfunction, such as rebreathing any CO2, an exhausted CO2 or soda lime absorber, and a leak in the ventilator circuit, and a faulty inspiratory or expiratory valve. Those can all cause an increase in tidal CO2. Now, for decrease, causes of decrease, the list is a little bit, it's not as deep. So for a decrease in production, hypothermia, pulmonary hypoperfusion, cardiac arrest, pulmonary embolism, hemorrhage, and hypotension, and an increase in alveolar ventilation, hyperventilation, and and equipment malfunction. So if we have a ventilator disconnect, esophageal intubation, complete airway obstruction, poor sampling from our sampling lines to go to our analyzers, and a leak around the endotracheal tube cuff. So if the cuff is leaking, that would show, we would see a decrease in tidal on our capnograph. Okay, so there's an arterial CO2 and end tidal CO2 difference, and the difference between arterial and end tidal CO2 is approximately 5 millimeters of mercury. So for example, if your end tidal is about 35, you can estimate that your PaCO2 is going to be approximately 40 millimeters of mercury. Okay, so problems that increase the difference. VQ mismatching increases the difference between arterial CO2 and alveolar CO2. And so the two conditions as given as an example would be a pulmonary embolus or endobronchial intubation. So the pulmonary embolism represents an increase in alveolar dead space that results from a sudden decrease in pulmonary perfusion without a change in ventilation. So we have increased dead space ventilation, but there is no perfusion going on because of the embolus. So now the endobronchial intubation we have perfusion, but we're not ventilating. So that actually increases the shunt that's within inside the lung there, because we're down usually the right main stem, and there's no perfusion. Like say if we left it down the right main stem without realizing that we're only ventilating the right lung, but not ventilating the left lung. So that's, and this is a very extreme example, but I mean, it could happen because some of these things have happened in the past. However, so there's perfusion, like say on the left lung, but there's no ventilation over there. So that would be the increase in shunting there. And then so we have some breathing pattern problems. So breathing patterns that fail to deliver alveolar gas at the sampling site, that increases the difference between alveolar CO2 and true end-tidal CO2, which so when the book is referring to true end-tidal CO2, that's referring to alveolar gas. So the alveolar CO2. So, for example, like in neonates or infants, because they have a rapid breathing rate, and COPD or bronchospasm. So the rapid respiratory rates and which can lead to not completely exhaling, the alveolar sample actually needs to be delivered to the sampling site, right? And it needs to remain there long enough to be measured. So if the patient is breathing so fast or not completely exhaling, like with a bronchospasm or with COPD patients, the alveolar sample isn't actually making it to the sampling site and remaining there long enough to be measured. So that can increase the difference. And so if we have problems with the capnograph itself, that increases the difference between the true end-tidal CO2, so the alveolar gas, and the measured end-tidal CO2, so the capnograph, so what we see on the monitor. So the examples would be a sampling catheter leak, calibration error, which sometimes can happen, and a slow response time that's relative to the breathing pattern. So, for instance, if the patient is breathing at a rapid rate or a rapid respiratory rate, and if we have a slow response time, like with a side stream capnograph or side stream analyzer gas sampling system, then we would have an increased difference between the true end-tidal CO2 and the measured end-tidal CO2. And if we also have the partial obstruction of the sampling system, so if there's water in the line or if the filter is saturated, then that itself can increase the difference. And usually that's an easy fix because you can just change out the tubing, because it's kind of hard to withdraw the water if there's actual water droplets that are inside the tubing. But if you just change out the tubing or change out the filter, it usually will resolve on itself or on its own there. And you would get that as long as the patient that has no problems and they're healthy, that normal approximate 5 millimeters of mercury difference should be there. Okay, so these are pictures of other ways to monitor the patient. And we get creative. So here is the sampling line just placed. Like, so this was this is a mask, and right here we're just placing it in there, and that's how we can, sometimes you got to get creative in anesthesia, and we're placing it there, and you can monitor end-tidal that way if you're if you have a patient that's on a mask, and there's a lot of reasons, like if you would rather do it this way versus the nasal cannula. Most of the nasal cannulas now actually have side streaming catheters attached to them, so all you have to do is just plug it into your monitor and you're good to go. However, if that fails for some reason, or if you need to give them a higher concentration of oxygen than what the nasal cannula is doing, and you move to the mask don't necessarily have this capability of having these catheters attached. So you have to get creative, and you put it on, and sometimes we tape the sides of these holes to increase the concentration of oxygen that we're giving to the patients. So we can ensure that we are monitoring, because it's a standard, so we have to make sure that we're doing it So, all right. So clinical measurement. So this is what I was talking about a little bit, a little while ago. And so clinical measurement, we know that it most commonly relies on IR light absorption techniques, which we talked about in clinical in monitoring. And so the greater the CO2 in the sample, the less IR light that reaches the detector. So that lets us, that's how it's being filtered, and that's how it's being absorbed. So just a little memory jog there. So with a chemical indicator, and that's the color change of the pH sensitive paper. So purple, no CO2, and when it turns yellow, there's CO2, so mellow yellow. Excuse me. I'm sure you guys have heard or said that before. And so the drawback with these is that it's sensitive to low levels of CO2. So even if the endotracheal tube is placed in the esophagus, it could still verify the esophageal intubation. So if we intubate a patient outside of the OR and outside of and without a capnograph being present, and we're using the a chemical indicator, we would still need to verify it by alternative means. So auscultation, rising chest fall, and chest excursion, and chest x-ray also. But by just listening to chest sounds and looking for rise and fall, you should be able to verify that you did not get it in the right location. Now, a lot of the times, if this is going on during CPR, because that's normally, or if this is in the ER, and you don't actually see the tube pass through the cords, you'll do the auscultation. And sometimes, you might have in-house radiology that's just right there, and that'll shoot a film for you. But usually, just through auscultation and looking for chest rise and fall, you would know that whether you got it in the correct location or not. So just know with the chemical indicator, you still need an alternative means to verify placement of the tube. All right, so monitor requirements. This is from Dorsch and Dorsch because this wasn't anywhere in either of your books, and it's actually pretty important to know. So our COT readings need to be within plus or minus 12% of the actual value. And manufacturers must disclose interference caused by ethanol, acetone, and halogenated volatiles or volatile anesthetics, and they must have a high CO2 alarm for inhaled and exhaled CO2, and there must be an alarm for low exhaled CO2. And these are just fail-safes because we just need to know what's going on with our patients. So we have monitors and alerts for just about everything you can think of with the ventilator. So on our time capnogram, we have different, when we're interpreting it, it allows us to see different things. So not only are we just interpreting CO2 values, but we can approximate our blood CO2 values that we talked about earlier, and pulmonary blood flow and alveolar ventilation as well. And so when we have a loss of exhales in tidal on our capnogram, there's differential diagnosis that we can kind of work through to make sure. So ideally, the very first one after we've intubated a patient is the esophageal intubation. And then there's accidental extubation, when the disconnection or failure of the sampling line or device, apnea, bronchospasm, or cardiac arrest. And so there are essentially four different phases. Sometimes there's a fifth phase there also, and we'll talk about that. But essentially for the time capnogram, there are the four different phases, and there are the inspiratory and expiratory that make up the inspiratory and expiratory segments. So the inspiratory segment is phase 0, and the expiratory segment consists of phases 1, 2, and 3. And we'll talk about those next. So this is a picture of the normal capnograph. So you see go back a second. So phase 1, phase 2, your alpha angle, phase 3, beta angle, phase 0, and we're going back down to baseline. And there's a phase 4 that usually can occur right here where the alpha angle is, or right as phase 3 is ending and phase 4 is beginning. And we'll talk about that and when that actually occurs. But so this is your baseline, which always should go back down to baseline unless there are some rebreathing problems or some other problems where we're retaining end-tidal CO2 and we're not exhaling it all the way out. So this is our expiratory phase, and then this is our inspiratory phase. Okay, so phase one. And so phase one, that's at baseline, like I talked about a little bit just a few minutes ago, and that's the exhalation of anatomic dead space and the apparatus, so meaning from the trachea, the bronchi, and through the endotracheal tube or the LMA. So that's the exhalation of anatomic dead space, or if you are measuring through nasal cannula, through the nose as well, through the nose as well. And so essentially there is no CO2 here. And approximately about a third of your tidal volume exits during phase one. So phase two, that's the expiratory upstroke, and it begins. And basically the anatomic dead space is washed out by CO2-rich gas, so alveolar CO2-rich gas. And at this point, this is where we can, the sampling of the alveolar gases begins, and it's normally fairly steep. Now, this upstroke can become slanted if the exhaled gas flow is partially obstructed, or if the side stream analyzer is sampling gas too slowly. So if it's aspirating at a slower rate or malfunctioning, or if the response time of the capnograph is too slow for the patient's respiratory response. So if the patient has a rapid breathing response, that you will see that this expiratory upstroke, if any of those three things are happening, you would see it become more slanted. So your azial angle would start to flatten out actually with that. So gas flow may be obstructed in the breathing system by a kinked endotracheal tube, or it could be within the patient's airway, such as with COPD or bronchospasm. Okay, so phase three is known as the plateau phase, right here at the top. And it's normally representative of CO2 in the alveoli, and it can be representative of ventilation heterogeneity, and thus the slight increasing slope. So we know that our lungs do not empty all at once. So if ventilation and perfusion were perfectly matched in all lung regions, alveolar gas would have a constant CO2 concentration, and the expiratory alveolar plateau would be horizontal, so it'd be flat. So since ventilation and perfusion are not matched in all lung units, CO2 will typically continue to rise, CO2 typically continues to increase slowly as a result of late emptying of the alveoli with the lowest VQ ratio, where they are the richest in CO2. So that's kind of why it starts out with its lower and then gradually increases, and that's just because of the ventilation heterogeneity, and that's the slight increasing slope. Now, so any respiratory pathologies that could be associated with an increase in ventilation heterogeneity could be asthma, COPD, or acute lung injury, and so that's a steeper upslope of phase three. So just as phase two will kind of become steeper and this alpha angle will flatten out, the alveolar plateau can become steeper. So it kind of looks like a shark fin, and I have some examples of these problems as they look on the capnograph as well, okay? If you gave a patient some PEEP or bronchodilators that have some of these particular problems with respiratory pathologies that are associated with the increase in ventilation heterogeneity, such as the asthma or COPD. So giving PEEP or bronchodilators would actually help that and help flatten out phase three and not make it so steep. Now, with phase 0, and now in some books it could be called phase 4, but most of the time it's called phase 0. But when I'm talking about phase 4 here, which we'll talk about in the next slide, but phase 0 here, so it's when inspiration begins. So basically there's the inspiration of fresh gas, and the remaining CO2 is being washed out. And so there's an immediate downstroke that returns to baseline. So that's the inspiratory downstroke. CO2 is being washed out, and inspiration begins, and it returns back to baseline until the expiratory portion begins. The occasional phase 4. So that is the occasional upstroke in PCO2 at the very end of phase 3. So your end tidal will kind of increase here at the very end of phase 3. And you just get this little hump right here. And so this upstroke probably results from the closure of lung units with lower CO2. And it allows for regions with higher CO2 to contribute to more of the exhaled gas sample. So that's why you see that little increase at the end. Now, this is seen in pregnant and obese patients, and that's usually due to decreased FRC and lung capacity. And whether it's called like an occasional phase 4 or a phase 4 prime, so like a phase 4 with like an apostrophe up there right after the V, it just depends on the author and who's writing the paper at that point, or the book. Okay, so the alpha and beta angles. So the alpha angle separates phase 2 and phase 3 right here, and it's generally between 100 and 110 degrees. Excuse me. Now, I know your books mentioned something about 90 degrees, but if you look at this, even if it's not drawn to scale, a 90-degree angle would be completely flat, but we always have this up slope. So that's just not accurate. So I'm not sure why it's saying anything like it. It's saying that the angle increases like greater than 90 degrees. Well, the angle is already greater than 90 degrees. So the angle will increase with an expiratory airflow obstruction, such as COPD, bronchospasm, or a kinked ET tube. And so when the angle widens, it becomes flattened, and you'll see like a shark fin, which I'll show you. I know I keep saying that shark fin, but that's just how I've remembered for all this time. So as the alpha angle flattens out, it becomes like a shark fin, pretty much, essentially. All right. So the beta angle, it separates phase 3 from phase 0, and it's truly at 90 degrees. So it's typically 90 degrees. The angle increases with a malfunctioning inspiratory unidirectional valve, rebreathing, and low tidal volume with a rapid respiratory rate. So if patients are taking just small breaths with a rapid respiratory rate, that the angle, this beta angle, will begin to widen as well. So the angle increases with the malfunctioning inspiratory unidirectional valve, free breathing, and low tidal volume with a rapid respiratory rate. Okay, so now we're just going to look at different capnographs and the problems that could be associated with these particular capnographs. And as you're going through this, like, I want you to kind of understand like any of the pathophys, or if it's a problem with the breathing circuit, as to why it's going to cause that abnormality in the capnograph. And so when you see these, hint on your exam and the future exams to come, you'll be able to recognize what's going on. if if you can see what's going on and recognize it immediately in the capnograph, then you'll be able to say, okay, this is what's happening with my patient, or this is what's happening with my breathing circuit. So the top one is just mechanical ventilation, a normal capnograph, totally normal. We got a normal alpha angle, we got a normal beta angle, we got a normal phase 0, 1, 2, and 3. Everything is looking good. We're returning back to baseline. So always just analyze, like go through and see what's normal and then go back to what's abnormal, and then you can kind of deduce and see what's going on. And this is spontaneous ventilation. So it's not ever going to look the same, like the same every time when you when the patient that's spontaneously ventilating, because sometimes they could take smaller tidal volumes or bigger ones depending on how deep they are, or if they have any narcotics on board as well. So this is spontaneous ventilation on the bottom. Okay, so this next one is the inadequate seal around an ET tube, and you see the sudden shortening of phase 3 here. So I love how it gives you like a normal one, and then you see, okay, you're like, oh, hey, going back down, going back to baseline, got an upstroke, okay, and looks like my alpha angle is okay, and then, whoop, phase 3 has shortened, and then our phase 3 is short, and then as our we're going down, and our beta angle is getting wide, and we're going back, and we're doing again. Okay, and that's simply because we're losing volume as we're exhaling. And some of that volume is going through the ET tube, and some of it's going around the ET tube. So remember, we're only measuring what is coming through the ET tube. So if we're losing volume due to an inadequate seal around the ET tube, to troubleshoot this, fill the cuff with a little bit of air, and you can check and see if with your next ventilation, if it resumes back to a normal capnograph. If it doesn't, then you may have to remove the ET tube and re-intubate the patient just to ensure that your cuff has an adequate seal, because the cuff could be leaking for a number of reasons. But you always want to make sure that the cuff has an adequate seal, because that is always your protection against airway, just in case your protection against any gastric contents or any other secretions, like maybe blood or anything, from entering into the airway. So if you have an inadequate seal around your ET tube and you add a little bit of air to the cuff and that doesn't fix it, just reintubate the patient. So here we have a faulty inspiratory valve, which is pretty much the problem for both of these. It's just they're both showing a little bit differently and what we see in phase 0. So right here we see, and you guys remember a little while ago what I was talking about, like how everything is normal, and then we have widening of our beta angle, and instead of we start to see that our phase, I hate when that goes away, our phase 0 starts to go down, but it's not going straight down here. It's widening a little bit here, okay? And then here we see that the patient is rebreathing CO2. And so that one is, and this is due to the patient has the inspiratory limb of the breathing circuit. CO2 has entered into the inspiratory limb. So this is what's going on here. As the CO2 re-enters the inspiratory limb, as the patient begins begins to breathe in, initially they're washing out the CO2, and then we have this extension here, right here, because it's extending phase 0, and then the patient, it starts to pick back up instead of reaching back down the baseline, because it should return to 0. But since we have some CO2 in the inspiratory limb, the patient is breathing in some of the entitled CO2 that was the residual that's been left over there. So these two are both due to a faulty inspiratory valve here. Okay, so this is a sample line leak. With the sample line leak, we see, and this is the one where it looks like it's, that occasional phase 4, right? But the difference between this, if you look, it's abnormally low. Like, look at this. because normally this would go up to closer to 40, right? Because we're measuring at, at least around 35, and then it goes up a little bit. But this is abnormally low. So this is how you know that this is a difference between just that occasional phase 4 that you would see in a pregnant patient or an obese patient. This is a sample line leak. So if you look at the beginning of the plateau phase, it's abnormally low because of the dilution of alveolar gas as the as we have atmospheric air that's being aspirated into the side stream sample. So somehow, some way, we're getting atmospheric air from the outside of our breathing circuit because of the side stream sample line leak. And you see that sharp peak at the end of phase 3, and that reflects a diminished leak due to the increased circuit pressure at the onset of inspiration. So just know that if you see this, it's not necessarily an obese or pregnant patient if the plateau phase starts at a lower amount than normal. If you have a normal plateau phase that's starting at, not a normal plateau phase because neither one would be normal, but if it's starting at a higher amount here, then you would know that could be due to a pregnant obese patient. But this is a sample line leak. Okay, so next we have hyperventilation. And so with that is a decrease in end-tidal CO2. And you see that the plateau phase is below normal as well. So it starts out being normal, and then over time it gets lower and lower and lower. And this occurs with hyperventilation, decreased CO2 production, and possibly inadequate seal with an LMA. So if you hadn't gotten it seated just correctly, or an increase in alveolar dead space as well. And so most likely it's usually due to hyperventilation, so that your patient is light. So you either let them start to wake up, or their anesthetics have begun to wear off, or you went down on their gases, they start to hyperventilate if you're letting them spontaneously breathe. Now, if you're hyperventilating them on the ventilator and there could be some different reasons why you would do that, this is what that would look like. But if because this is more of a mechanical ventilation pattern. However, if it was spontaneous ventilation, then it would look more like the little humps that we saw in that first capnograph example. And if you have an inadequate seal with an LMA, it's usually like it's equivalent to an equipment failure. So if you're just having a hard time with getting your LMA seated into place, because they can be difficult, you can scrap it. And then if you just feel comfortable and you just want to intubate the patient, just intubate the patient, because with intubation it's a lot easier to manage if you're having problems with an LMA. And as we talk more about equipment and the differences between the different sizes of an LMA, you'll have some patients that sit in between, like maybe a 3 and 4 if they're a woman, and if they're a man, they could sit between a 5 and 6, and that could make it more difficult for it to seat and seal well, and just due to anatomy also. All right, so hypoventilation, we see an increase in end-tidal CO2, so it's just marching on up, just getting higher and higher and higher. Now, with hypoventilation, there's an increase in end-tidal CO2, but you still see that the baseline returns back to 0. So this occurs with an increased CO2 production or decreased alveolar ventilation. And normally we see the decrease in alveolar ventilation if we're deepening our anesthesia or if we're giving opioids. We'll see that increase in end-tidal CO2. And so an example of increased production, MH, sepsis, fever, hyperthyroidism, thyroid storm, and like I said, decreased alveolar ventilation if you're hypoventilating the patient, or narcotics, but usually it's opioids or narcotics are going to be the culprit there. All right, airway obstruction, the shark fin, finally. So we see you see that this could be an obstruction in the airway or in the breathing circuit. And so we see our changes in phase 2. It's flattening out and becoming steeper, and our alpha angle has flattened out, right? And so We said that if phase two becomes slanted, and it could be because of exhaled gas flow is partially obstructed. The side stream analyzer is sampling gas too slowly, or the response time for the capnograph is too slow for the patient's respiratory rate. So but most of the time it's COPD, asthma, a bronchospasm, or a kinked ET tube. And so, if you see a shark fin, think that if I'm having a problem getting the air out, like what's causing my patient to obstruct, and why are we having this problem? So COPD, asthma, bronchospasm, ET tube, or a partially obstructed breathing circuit. Think about those. So that is your shark fin right there. All right, so cardiac oscillations. So we see cardiogenic oscillations, and we usually see them at the end of the exhalation phase, and you see them going into like the beginning of the inspiratory phase as well. And it's usually at the end of exhalation as the flow decreases to zero, and the beating heart, because it's in close proximity, causes emptying of the different lung regions, and that back and forth motion occurs. And so when we think about it, we have remember, during exhalation, our lungs are full, so they're fully expanded. So as our alveoli are emptying and our lungs are decreasing in capacity, the oscillations can be more visible, or are more visible and visibly seen in our CO2 waveform. With rebreathing, if the inspiratory baseline is elevated and the carbon dioxide is greater than zero, we know that CO2 is being rebreathed. So look, as we're now returning back to baseline, we're getting a little bit higher, so we know that our end tidal CO2, or our CO2, is being rebreathed. And so if you look here, we're just never returning back to baseline. So a differential diagnosis could be an incompetent expiratory valve, exhausted CO2 absorbent, or gas channeling through the absorbent as well, or an imperfectly calibrated capnometer, which that could happen. But more than likely, it's your soda lime, or your soda lime is being exhausted. So if your soda lime is being exhausted, you can change it, and usually after you change it, you'll see, even if you have gas channeling through the absorbent as well, you can change it, and you would see that return back to baseline. Otherwise, if it's not returning back to baseline, you've got an incompetent expiratory valve. Okay, so that's causing the rebreathing. Because usually your capnometer is just not going to be miscalibrated through the middle of the case unless something absolutely happens to the analyzer for some reason. So always try and explore and see what your differential diagnosis is if your soda lime is just fine. Okay, so this one, we see some spontaneous breaths that are occurring here. And so more commonly called the QRA cleft. So if you look in phase 3, you see that dip right in here, and that's a patient just taking a spontaneous breath during mechanical ventilation. So that's nice, but sometimes it's not good, because if you're in a long case and the patient needs to be reparalyzed, it just means that they may have, 3 or 4 twitches or something, or maybe even sometimes 2 or 4 twitches. So you just give them, a little bit of rock or Vec or atracurium or cisatracurium, whatever you're using. Give them a little bit more, because you don't need to use like the full intubating dose. Just give them a little bit more, and in a few minutes, that spontaneous breath will go away, and as they get more paralytic on board. So also, it can suggest inadequate muscle relaxant reversal if this is present during spontaneous ventilation, and this is due to a lack of synchronization between the intercostal muscles and the diaphragm. So that just means that you need to give a little bit more relaxant, or not relaxant, I'm sorry, reversal, or wait a little bit longer because the patient isn't adequately reversed. So maybe you tried to give them some reversal when they only had 3 or 4 twitches. They weren't very strong. So you always want to remember, rule of thumb is that they need to have 4 twitches, and you want them to be strong twitches, not 4 twitches with fade. You want them to be consistently really strong because you don't want inadequate muscle relaxant reversal because it's not good when you you extubate a weak patient and you still have to go back to the PACU to reintubate them or something because they aren't able to maintain their airway. Okay, so over breathing the vent. All right, so here we have breaths that are in between our mechanical ventilation, and that's a spontaneous breath. And it's spontaneous breath, so that their muscle relaxant has definitely worn off. But and sometimes this can happen if you're just like letting them wake up and you're letting them try and get them to rebreathe. If you still have the ventilator on, so if you have decreased the rate and maybe you were ventilating them at a rate of 10 or 12 and you decreased it to like 6, and a lot of us will decrease the rate to 6 or sometimes even 4 to let that CO2 climb to stimulate them breathing as the muscle relaxants have worn off, and then you start to see them take breaths, and then you see these small spontaneous breaths in between the ventilator breaths, and then they get bigger as they become stronger, and then from that point on you can switch off the vent and then just let them breathe with the APL on, just adjusting the pressure as you need it and giving them supportive breaths if you need to. Just give them just a slightly bigger breath until they begin to wake up. And you can do this with gas on, just depending on the type of surgery and what's going on. If you just want to let your patient spontaneously breathe after you've intubated them and you want to get them back breathing and let them spontaneously breathe, that's totally fine. And you just use some narcotics and some gas. And use narcotics and gas just to get them down and not paralyze them, but just keep them down so they're not moving or anything, but they're breathing on their own. All right, so last but not least, intubating the esophagus inadvertently. So when we intubate the esophagus inadvertently, we see this big carbon dioxide. So you think, yeah, I'm in there, but it's not, because it's usually from when you were breathing down the patient to get to, and you were breathing for them while the muscle relaxant or the propofol was kicking in. Some of that gas and some of that CO2 ended up going into the esophagus, down into the stomach, and got trapped. So when you intubated the esophagus, that first big rise of CO2 is just trapped CO2 that's in the stomach or the esophagus. And then as you keep ventilating, you see the CO2 go away and then ultimately comes flat because the CO2 has been ventilated or it's out now. So you just withdraw the ET tube and start all over and just aim for the right hole this time. Okay, so that is it, guys. So I'll see you on Monday. We'll talk about this and go over some things and just to get prepared for the exam. And like I said, you'll get these questions on Sunday. Feel free to email me if need be. And that's it. Have a great night.